All right. We will begin the afternoon session, and we are very excited to have leadership both from the Department of Public Health and from a really critical partner organization. So I will introduce all three, and then we will hear first, I think we'll hear sort of from that direction. But we have with us Dr. Barbara Ferrer, who is the director of the Los Angeles County Department of Public Health. And Dr. Jeffrey Gunzenhauser, who is the Disease Control Bureau Director and the Chief Medical Officer for Los Angeles County for the Department of Public Health. And someone who's been very engaged with HIV as responsible for this whole component of public health. And we have with us Louise McCarthy, who is the president and CEO of the Community Clinics Association of Los Angeles County, which is the association of federally qualified health centers, community clinics. And you have many of them, and they are, many of them, very engaged in HIV. So we will hear, we have a few slides, and then it will be a discussion among them, and then we will have just initial questions, and then again we will have a sort of broader reflection from anyone who wants to make a comment or ask a question. So we'll begin with you, Dr. Ferrer. Oh, with Dr. Okay.
So, good morning. Okay, now can you hear me? All right, thank you. So I really want to say thank you. I know Barbara and I both really appreciate the opportunity to come speak with you from our positions as leaders in the Department of Public Health and how we can see from our points of view how we can help with this work around ending the HIV epidemic. Before I share some of my specific viewpoints, I do just want to share with the group, you know, when I started in public health back in the mid-'80s, I actually worked with Dr. Redfield. I had completed my clinical training up in San Francisco and got an MPH in Berkeley, but then I went back to DC where I was completing my preventive medicine training, and Dr. Redfield was a young infectious disease physician over at Walter Reed, and he was creating this whole clinical care system, and he needed help from the public health side for a lot of the community work and all the sort of tracking and other things that were needed. So I got very involved for a year working with him to develop that clinical care delivery system and a whole bunch of other things, and I was very involved with that for quite a few years. So I just, to work with him then and see the vision that he had and saw how that played out, and now to have him come here to Los Angeles again and going around the nation, again with this vision of ending an epidemic, which, as you know, back then we really didn't have any tools or resources to do the things that are really needed. So for me, just personally, it's a sort of a fantastic closure to be in a position where I can really help with this. So to talk a little bit about leadership, we have a great opportunity in our department to provide some leadership for this. And from my point of view, it's not really a question of whether or how will we do this. It's really how we're going to do this. From my perspective, as a public health physician, where I've been involved with a lot of communicable disease outbreaks throughout my entire career, and looking at what we're proposing to do here, to get from, as Mario says, 1,800 infections down to 500 within the next 3 or 4 years, or however we want to frame that, is an extraordinary endeavor. You saw the timeline going from 2008 to 2017, 22% reduction. We're talking about making a massive turn on that curve and heading, not just 22%, but 75% in a period of 3 to 5 years, and that's just going to be an extraordinary effort. There's no way that can be accomplished without extraordinary leadership, extraordinary teamwork, a lot of accountability and tracking of things that need to be done. And of course, with HIV, there's all types of issues around racism, social inequity, social injustice, the stigma that's been talked about constantly, which really raises the bar on all the things that we need to do. A couple other things that I do want to highlight, this whole effort has really stabilized. If you look at the national rates, they've really leveled out, and there's a lot of things going on that we're really at risk that this could go in the opposite direction. So we really need to redouble our efforts to make progress in the direction that we want to go. From my point of view, this is really transformational leadership that's needed. And from my experience, there's really 3 things that are needed to accomplish that type of vision. First is a clear direction. Right, so leadership has to get together. We have to share creating that vision. but it has to say this is where we're going. It could be something as simple as Mario has said, we're going to get to 500 infections by some year in the future, and that's sort of our vision. The second role in transformational leadership is alignment, right? This is where we have so many partners and players, and once we share the vision, et cetera, we have to then have everybody align their work trying to pursue those same goals. And there's an awful lot of work there because there's a lot of communication. There's a complexity of understanding what our metrics are going to be, what everybody's role in, and getting that unification. And the third thing that's really required for transformational leadership is commitment, right? We really need everyone who's a partner in this to ante up and be willing to say, yes, I will do X. So there's many partners here that are already doing extraordinary work, but there's a lot more partners that we have to engage with throughout Los Angeles County that have to commit. And so that takes a lot of leadership to get that kind of commitment, to build the trust, to see the value, and to incorporate their suggestions and ideas so that it's all seen as though we're all working together. You know, the last thing I will say is that from my position, and we really need to track on a more real-time basis metrics. In order to turn this curve and eliminate these infections, we're going to have to track the number of people who've been tested. And I know that a lot of this is being tracked, but there's some of this that we're not really tracking very well. So, you know, the retention to care and the viral suppression we have. But we really have to have better tracking of the number of people on PrEP. We have to really track the effectiveness of our syringe services programs. We really need to track the activities that are related to the social issues that are so important to this as well. Short of tracking those, we're likely not to be successful. So we really have to come up with a near real-time system that will allow us to do that. So for example, you know, we talked a little bit about mumps just a couple of minutes ago. But like when we're responding to mumps, I need to know a clinical result tomorrow. And then I need to know the vaccine is going to be here tomorrow. And I need to know we have staff deployed tomorrow to do what's needed, not 3 months, not 6 months, or not a year. So I know we'll never reach that pace of responsiveness, but we should try to approach that. So we are tracking measures and we're deploying what's needed to address the things that are going to help us to turn the curve. I think that's I'm going to close my comments with that, and I'll yeah. Thank you. Barbara pointed out I did show you the slide. So up here you can see there's the voice for ending the epidemic. There's the voice for ending the epidemic. There's the importance of addressing the needs of various communities that are vulnerable, and then there's, from our department, we need to maintain this as a high priority, which I commit to doing in my position. The main areas of opportunity are, you can see there's a bunch of areas for synergizing. The first area of synergy is aligning with a lot of the county level priorities. There's also an opportunity to align with our own department, a lot of the activities that we have going on. You can see that's up there. And then there's we have to really have closer coordination with our community partners that aren't engaged. The really challenging one down there is closer collaboration with all of our healthcare partners. I know Louise is going to talk about the Clinics Association, but there's many other partners out there that need to be helping us with testing and care, promoting PrEP, and a lot of other services that are needed to help get testing done. So those are the opportunities that I see. So with that, I think I'll turn it over to Dr. Frere.
We could leave it on this for just a second. So good afternoon, and thanks so much for allowing us to come and talk. I first want to applaud everyone who's here in the room. I know when Jeff talks about leadership, he's talking about all of you. He's really not talking about us. I mean, I think what we depend on is actually that the folks close to the ground experiencing either, in this case, adverse outcomes or distress or in need of services, and the folks that are there to be helpful and be of service really are the folks who provide the leadership to how we end the epidemic. Our job here, I think, at the Department of Public Health is to support the efforts, both from the commission, obviously, which I think is a tremendously important and critical partner for everyone who's in the room, and I'd like to thank them, applaud them for all of the work that they've done to get us here and all of the work they continue to do to make sure we move forward. But I want to acknowledge straight out that we're not the sort of the leaders. I mean, we have leadership roles in our organizations, but the real leaders are the people who do the work every day. The real leaders are the people who have experiences that need to influence the work. And our job is to elevate those voices, to pay particular attention to folks who have been marginalized and not at the table, to take seriously our obligation in listening, to be responsive, and then to march together with you on this path towards ending the epidemic. I do want to note that one of the places where I think, as a department, we have a helpful role to play is thinking about the interconnectedness of some of the issues that you're grappling with and some of the issues that we're grappling with. So I want to highlight the issue of folks who are often left out or disproportionately affected by bad outcomes. So I want to in particular talk about folks who may be incarcerated and folks who may be homeless, because those are also folks who may be HIV positive or may have a higher risk of becoming HIV positive. And I want to say, a person's a person, and with all of their complexities, and slicing and dicing, because our program funding is sliced and diced, makes absolutely no sense when we're defining how systems ought to work. And here's where I think, as a health department, we can have a critically important role to play, which is understanding that the decisions we make about care first, jail last, the decisions we make about how, in fact, to be respectful of people who are homeless and listen to what their needs are and then create systems that can respond. The desire for us to address the fact that mortality amongst homeless people in LA County is surging. It's almost at the rate of 1 out of every 60 to 80 homeless people is dying on the street, and it's at a rate that's directly linked to higher rates, significantly higher rates around issues related, for example, to overdoses. So if you're a homeless person today in LA County, you're 28 times or 29 times more likely to die than a person in the general population from a drug overdose. 10 times more likely to die of a homicide, 5 times more likely to die from suicide, 22 times more likely to die of coronary heart disease. These should be alarming numbers for us, but they speak to the very same issue. We have folks who have been so marginalized and so left out that they're refugees from economic systems and social systems that do not work for them. They are refugees from economic and social systems that are not working. And as we think about ending the HIV epidemic, we have to pay particular attention to the folks who are so marginalized, to the folks who are not able to be engaged, to the folks who are not respected, and the folks who have found no home or place to call home here in LA County. And by a home, I don't only mean where their physical location, I mean a home where they're loved, cared for, and respected. And that can be a service organization, or it can be a physical location in our communities. But I do think it's one of the areas where some of the work that we do as a health department in other areas should be intersecting with the desire for us to get to no new infections, no new HIV infections in LA County. And I want to commit that we work diligently with all of you to figure out where those connections ought to be in the design of services, as well as the design of policies and practices, because I think they're all interrelated. And I think they're all exceptionally important for us to pay attention to. I don't think we get to zero if we ignore a subset of the population that at this point has the worst health outcomes across LA County. And there obviously is intersectionality there with racism and homophobia and sexism. So I'm not ignoring these larger issues that intersect, but I do want to call out that we have a significant problem with a group of residents of LA County that are, as I noted, refugees from systems that are failing them today. And I call us all to pay particular attention to how we can think about our work a little bit differently so that we end issues related, we end homelessness. We end the fact that people who need treatment don't get treatment, and we end the fact that if you're either homeless or in need of treatment, the best place for you to get entry into those services is by going to our jails. So that should be on all of our conscience as we move forward with creating better alternatives. I did want to give a little bit of an update, which is kind of the segue, is that the work that we do on these larger policies is work that traditionally we've thought of as health agency work. This is partnerships between the three departments of health, the Department of Health Services, the Department of Mental Health, and the Department of Public Health. And as many of you know, we were asked, the three department directors were asked a couple of months back to revisit what structure would best support the integration of our efforts. There's no wavering, either from the board or the three departments, on the need to continue with full integration around a subset of our actions. But there is, at this point, acknowledgement that we may not have the best structure with the health agency structure to support the work going forward. So yesterday, in response to the board motion, we actually filed a memo back to the board that really laid out an alternative way for us as the three health departments to come together, do our integration work, and again, work effectively with all of our communities, with the board, and with all of our staff. You know, we probably have almost close to 40,000 employees, county employees, between our three departments. So we have a huge need to make sure that our working environments mirror what we're trying to create in our communities. They're respectful environments, they're just environments. So that's a big piece of our work. But I want to just allow you to just have a moment to just sort of see where we're headed. And again, this is now up to the board for them to review and then get back to us with their ideas about, does this make sense and is this the way to move forward? I do want to say that I did meet with the leadership team, the executive, is it committee? The executive committee of the commission about a week and a half ago and did a more formal presentation. We've met with all of our different commissions and stakeholder groups throughout the last month and a half, trying to, again, solicit some feedback on what we're proposing, and we've made a lot of modifications because we had a lot of wise counsel from folks. But the purpose of what we're now going to call the Alliance for Health Integration is to improve the health and well-being of LA County residents by aligning and efficiently implementing board-approved prevention, treatment, and healing initiatives that require collaborative contributions of the three health departments in a manner that supports our workforce, builds partnerships, promotes health equity, and respects each department's unique charge and scope. So we're clearly defining why we're going to come together in this very deliberate way. And I want to be clear that we take direction from the board. We did before when we were a health agency, and we will continue to do so as an alliance. So we're not changing this notion that the three of us independently and now as an alliance are responsible for working and work for the board. There is a new proposed governance. It's a consensus governance structure where the three department directors come together They make collective decisions on how to best advance work. I want to note that under the health agency, that was in fact the reality as well. So while this is now highlighting what looks to be a very different, consensus building structure amongst 3 department heads, it is in fact how it's been operationalized since the inception of the health agency. There is no work that has moved forward in the health agency that has not been a consensus decision amongst the 3 departments. In fact, that's because of the way we fund the health agency and the way we've been structured. Each of us reports independently to the board, as did the health agency director. There never was, we were always equals at the table, and as equals we collaborated to move work forward. We would have a lead facilitator that would be a rotating role amongst the 3 department directors. So every year there'd be a different lead facilitator. And their job really is to facilitate and serve as a point person for that year. We would be hiring staff. There's already been an allocation, but instead of there being sort of a CEO level person, there will now be a COO person. This would be an implementer of the initiatives that move us closer to the integration. Again, nothing's changed on the financing. The 3 departments are responsible for all the financing of that. We're responsible for the health agency and remain responsible for the financing of the alliance. And there's no intent here to create a new bureaucracy. So there's a very small number. There's 7 items, 7 positions that are allocated to this effort. They're really project managers and the COO and an administrative support person, with the bulk of the work being done across the 3 departments. That also hasn't changed. There is no desire to have a 4th department or a huge infrastructure for another department. So, we're not proposing that, and we don't see that the board is wanting us to move in that direction. We did list out the priority, sort of big bucket priorities. We have floated as well a more detailed proposal on this that spells out some potential activities and objectives and metrics. But I think what's important here to note is that the 3 areas of important work continuing to move forward: integration and development of prevention, treatment, and healing services, reduction of health inequities, and improvement of organizational effectiveness. There's ongoing work in all of these 3 areas, and these are all areas where the board has been very articulate about the need for us to do a better job in an integrated approach across the 3 departments. So I want to, just make sure everyone has some information on this. We're obviously going to wait for the board to get back to us. But I bring that up because I do think ending the HIV epidemic is a goal of all 3 departments, a shared goal of all 3 departments. And as we move our work forward, we ought to be able to benefit from the integration efforts that would now happen under this alliance or some other structure that the board asks us to pursue. So, and I'm going to stop my comments.
Okay, I think they're pulling up my slides, and I've got my microphone, so I'm going to sit forward so I can see a little bit here. As mentioned, I'm Louise McCarthy, and I run the Community Clinic Association of Los Angeles County. We are the coalition of all the community clinics and community health centers in LA. So that's Antelope Valley down to Long Beach, Venice all the way into the San Gabriel Valley. And we are a conduit between our members and the world at large. One, trying to make sure that we're bringing issues to them and resources to them, but also making sure that we're listening to them and hearing their voices on the ground about what matters, what needs to be addressed, and we seek both policy solutions to this as well as provide training, technical assistance, and shared services and supports. We represent 64 organizations that have over 350 sites countywide, and our members serve over 1.7 million Angelenos every year. I'm here because this issue matters to me, and this issue matters to our members, and this issue matters to LA County. So I just really want to make sure that everyone here in the room understands that ending the epidemic is absolutely a priority for the community clinics and community health centers in Los Angeles County. Just as far as 2020 goes, we had a strategic plan that started in 2015. We went for 3 broad goals, because I like to keep things broad and see how I can fit everything in. But those goals are integrate, innovate, and demonstrate. 1, integrate services, integrate data, integrate with partners. We see community clinics and community health centers as key hubs and places where folks can go to get resources and services. They're key partners to do that as well. And so that is one of our priorities. Innovate. We really need to think about how to be performance-driven, innovative organizational cultures, especially in a world where we're often being asked to do more with less. It's important for us to think about how to do that. It's important for us to look at the metrics and look at the data and say, is what we're doing working? And if not, what do we need to change to do that? How do we elevate the best practices that are out in the field to make sure that those innovations are spread not just countywide, but nationally? Because we do recognize that Los Angeles is an incubator for much of the nation. And we can drive very innovative policies and practices here in Los Angeles. And finally, demonstrate. We have to show our value. This became more important than ever in 2016, 2017, and up till today, as we have to demonstrate that, yeah, it's important to cover people with insurance, to provide them a Medicaid expansion. It's important to provide resources to community-based organizations to make sure that people get served where they live in a culturally competent way. Not the patients need to see our value. The workforce that we're struggling mightily to hire all the time, they go thrive up on Sunset, if you know what I mean. We need to show them our value. We need to show the health plans our value and our other partners our value as well. So those are our goals for 2020. We'll actually be working this year on refreshing those goals for the next 5 years. And I anticipate that the issue of health equity will absolutely be incorporated into our strategic vision going forward. I'm going to pause for a quick moment, and I just want to recognize that here in the room, there are a number of our members. If you are with one of the community clinics or community health centers, could you just raise your hand? Okay. I see you over in there. If you're affiliated with a community clinic or community health center, raise your hand. Do you partner with a community clinic or a community health center? Okay. The rest of you, we'll get you soon enough. So I'm going to share some data points starting nationally, and this is national data just on the community health centers. So this excludes the community clinics, including our Planned Parenthoods and others here in LA County. But just to show that, one, for people nationally with a known HIV diagnosis, 16% of them nationally are served by community health centers. For folks with a known diagnosis who receive care, 22% of them are being served by community health centers. So it's a proportion, it's 1 in 5, but it's still, there's room to grow. Also, just community health center data, not clinic data, looking at the number of patients and visits that have been provided by the community health centers over the last several years. Since 2012, we've had an 8% increase in the number of visits, but we've had a 44% increase in the number of patients. So we are seeing progress in that arena as well. And in testing, this is my little woohoo moment, is that we had a 682% increase in HIV testing in community health centers nationally. Like I said, this matters to us, and we're here because we care about this issue very, very deeply. I think Mario might have mentioned in one of his slides earlier, talking about some of the funding opportunities. There are, as we know, with the federal initiative to end the epidemic, there are different funding streams coming out. One of them is specifically focused on primary care HIV prevention. And so this is a 2-year program. It's going to start in April, And the purpose is really to expand prevention services to decrease the risk of HIV transmission, and focusing also on supporting access to and use of PrEP. For folks that are eligible, they already have to be working in this arena, and they have to be in a geographic location that we know is at a high risk. And so LA is absolutely one of those areas that's being targeted. And the 14 organizations that I know are active in the commission, active in Ryan White, and active here across LA are eligible for this funding, and I hope will be applying for this funding. If you're not, let me know. But they will be able to apply for this funding. The real objectives of it, one is outreach. Can we engage new and existing patients in HIV prevention service? Can we identify those at risk and use validated screening tools? Looking at on the side of testing, increase the number of new and existing patients tested for HIV, looking at PrEP prescriptions, and also linkage to treatment. Something that I want to really highlight in this funding as well, they talk about partnerships. In the notice of funding availability, it's really important to include community partners and others if you're doing this work, because we know that the work that we do on the ground is only elevated by the partnerships that we have by other community-based organizations and agencies, public partners, and others. So that's absolutely critical. So stay tuned for the April announcement. I'm fingers crossed that we clean up in Los Angeles on this funding, and that we're actually able to move the needle with this and all of the other funding streams, initiatives that are going on nationally and here in Los Angeles. Just a couple other notes as far as our organizations. I mentioned that there are 14 organizations here that are quite active. 74% of our members are involved in Ryan White Part A. 75% of our members are involved in Part C. And one of our members, which is 70% of the Part D providers here in Los Angeles County. 7 of our members are also PrEP Centers of Excellence, and that's 70% of the Centers of Excellence for PrEP here in Los Angeles. Now, as far as making an impact, you know, this isn't just about what we've done, this is about what we're gonna do and how do we do it better. I said the word partnership, I can't emphasize that enough, but I have to really emphasize the piece of it being meaningful. It doesn't just mean I'm going to send someone your way and, hey, bye, now you're going to take care of them. It means that we really get together and we work together. I was just on Crenshaw Boulevard 2 days ago where the Black AIDS Initiative is co-locating with St. John's Well Child and Family Health Center, where they're actually going to be under the same roof doing the work together. Co-location isn't necessarily integration. You have to work out MOUs, you have to work out referral relationships, you have to do work between your teams so that they're actually meeting and talking together and using the same language. I'm going to use an example in the world of, well, mental health and here as well. Sometimes we say the word patient, and that's a no-no word for a lot of programs. But when you're in the medical world, you say that. But in other places, we need to say client. In some places, we need to say consumer, and I'm sure there's a million other words that I haven't even thought of yet. But it's important for us to learn to speak the same language in order to have a meaningful partnership. Because using trigger words on your partner is not going to help you have an effective outcome. Additionally, when we think about multi-sector partnerships, our members are partnering with transportation, with food, with housing, you name it. We are open for partnership, and it has to be multi-sector because we know that the people we serve aren't always coming to us first. And so it's absolutely critical that we use multi-sector partners to be able to cross-refer, share data, share information, and share best practices. The clinics have a unique ability to follow their patients, clients, consumers, people. They have a unique ability to do that. They have the data, they have the systems, they do the outreach. So leverage us. get to know us. If you're one of the people that didn't raise your hand, how can we work with you to help us serve our common population better? We also need to think about specific populations and specific geographies. For example, women. At this point in time in Los Angeles County, there is a gap in HIV care for women, in particular, and also in getting services like PrEP to women. So we need to think about how, and then there's other geographic areas and specific communities that we haven't done a great job at yet. So we need to look at those communities, look at those populations, and think about how are we going to serve them better, and how can we do that better with you. And I hit 2 bullets with one. And then truly integrating PrEP into practice. For example, Planned Parenthood is one of our members. And when looking at their integration of PrEP, they took apart their whole operations. They said, let's integrate PrEP into our operations and not just make it an add-on service. When I see that our members have HIV specialists on staff, I'm glad, that's great. But I want to make sure the pediatricians and the primary care providers are doing this work as well. It needs to be integrated into the usual course of care. Our school-based health centers, for example, if they're seeing people who they're identifying as being at risk, they need to be comfortable with prescribing PrEP. It's absolutely critical that we integrate this into practice. Thank you. And we not just wait till those students become another at-risk population that does indeed that has indeed been exposed. And finally, and something that's really our juice as CCLAC and our members, and I think here within the commission as well, is that we need to share and elevate the best practices. We need to learn from each other, create learning communities. One of my members said that she actually learns best from worst practices. Tell me what you wouldn't do again. Right? We've learned a lot of lessons. We need to share those with each other to think about how are we really going to advance care and move the needle on this issue. So those are some of the things that I think about and my members think about. And I do want to just give credit to my members and my team because they are the specialists on this issue, not I. And they did provide good feedback for me as I was preparing for this because I didn't want to come in as a gadfly and say that I knew what's going on. I rely on them for the knowledge and for the expertise. And that is, those are my comments. So thank you very much.
Thank you all. Do either of you have questions to ask each other or things that you think it would be helpful to hear from each other? And then we will get to the rest of the room.
How can we be a better partner?
I mean, I think the issues on partnership are definitely, they have to go both ways. You know, we've been working, I think, with some of the community clinics and the community health centers more intentionally than with others. So I think the issue is, like, what could we learn from where we've built up really strong relationships and strong partnerships that would help us really sort of broaden that scope. You know, many of you know that, for example, we've partnered with Planned Parenthood of LA to open 50 student well-being centers in 50 high schools. And I think that's the sign of a really great partnership and the ability to really share with each other a very limited set of resources. And we've got different partnerships with different community health centers around a variety of initiatives. But I think you're right, you know, for the partnership to be as strong and as powerful as it ought to be, we would have to have relationships with all of the community health centers and the community clinics. And I think the place to start is to look at what's working well and learn from that. I don't know, Jeff, if you have other ideas.
Yeah, just a couple ideas. To the extent that we know one another's work and we can communicate, we've got this shared agenda and we agree we're going to approach it this way. You can say, I'm doing this part while I know the Department of Public Health and the other players are doing their part. So I think it's really important for us to develop that collective awareness that the strategies we're applying are the best ones and we understand who's doing them among us. It's sort of a leadership function. The other thing is we have to communicate to all of our partners a similar vision. If we say we're trying to get to a certain goal and you communicate a little different and the CDC is saying something else and the state has a different vision, it gets really confusing to people. And they wonder, so to the extent that we create that shared vision of where we're going and we're all communicating it together, there's a lot more trust in the community that what we're doing is valid, that we're all working together and we're not being inefficient. So I think all of it is just us communicating better, creating that shared vision, deciding what we're going to do, and understanding what one another is doing. I think that would all be very helpful.
Thank you. Any other question here? Should we open it up?
I'm okay.
I think we could open it up. Okay. Yeah. Questions, comments?
Uh-oh. My members are going to ask, uh-oh. I'm just going to turn it back on you. You know it.
Okay, please.
Is this on?
And
Can you hear me?
identify
Okay.
yourself.
Yeah, so I'm Katya Nelson. I work at APLA Health, and I'm also the co-chair of the Public Policy Committee for the Commission. So thank you all for joining us today. I have a question for Dr. Ferrer. So you discussed the Alliance for Health Integration update, and you attended our October Executive Committee meeting to go over it and solicit some feedback from us. And I think the key recommendation from us was to include HIV in the sub-goal around addressing STIs under the goal 2 of reducing health inequities. So my first question is, was HIV included in the sub-goal in the draft that was submitted to the board
Yes.
yesterday? Okay.
Yes, it was.
Great. And then second, a little bit different question. You recognize the community as leaders in efforts to end the epidemic, and could you speak a little bit more about what you will do in your leadership role, in your county leadership role, in partnership with us as community leaders to support doing the work needed to end the epidemic?
Sure.
Thank you.
You know, I so appreciate that all the work that went into the strategic plan. So, I'm going to go back and just say, our job is to make sure that we're full partners on the implementation of a strategic plan. Like, people spent a lot of time figuring out what the roadmap was for LA County. It's our job to make sure that we're full partners on the implementation. We don't have a separate plan. Your plan is our plan. That strategic plan stands for us, and it aligns for us how our work moves forward as much as it should for everybody else who's working in the county to end the epidemic. So I want to say, I think the biggest obligation we have is to follow the roadmap you gave us and figure out where it makes sense for our resources to either be realigned so that they're more sensibly supporting the roadmap, or where we have to work with others to find additional resources. I don't think there's no magic bullet on the resource question, and there's no way to ensure that we have all the resources at this moment to implement the entire strategic plan. But I think there's a deep commitment from us to look at how resources are currently being allocated and see where there's a need for realignment, and then to advocate on the policy side for making sure that we get the resources into this county that we're going to need to fully implement what I think is both an ambitious but appropriate strategic plan for the county.
Women first.
Okay. Thank you, Abad. So, hello, panel. Good to have you all here. So, my question is going to be a little bit of a long question, but I want you to think about it in the context that you all feel every day, where there is no safety net for not just residents of Los Angeles County, but for residents of the United States. There is no safety net. So, but for the grace of God, you get ill, you lose your job, and then you're on, quote, public assistance, right? So if you could think about that with that context, and I also need you to think about it when people are referred for services and then referred again, and they get deferred and they never get care. And how can we treat people compassionately on a consistent basis when they come through our doors? So the commission is required by HRSA to do an assessment of administrative mechanisms, the AAM. This involves evaluating how rapidly Ryan White Part A funds are allocated and available to people for care. We want to make sure that there's accountability in that care too. The assessment found that it is currently taking 18 to 24 months for complete solicitation and contract execution cycle to occur. It's a very long time for people who are in desperate need, and we need to see huge changes in this. So what is the county and the Department of Public Health leadership doing to streamline that contracting process and to assure that the help goes where it's needed?
Thanks a lot. That's a great question, and a source of both discomfort and frustration, I think, for all of us at the Department of Public Health. I don't have an easy answer. In part, I don't have an easy answer because some of the rules around contracting are not department specific, and they're actually county specific, which means that getting some changes made is not as simple as coming to agreement within any one department, but needing to get changes across a vast bureaucracy, for good or for bad. You know, there's something to be said about uniformity, so I don't want to paint this as sort of this ugly picture, because in fact, you know, the desire at the county level is that there be uniformity. But that also means that every department can't just go ahead and change the rules around contracting. I do want to say that we have, as one of our priorities, been working already on simplifying contracting. It's one of the goals of the 3 health departments. For starters, we're trying to figure out how we can avoid having the same vendor or the same business or the same clinic have to have 3 contracts with the health departments, one for each of us.
Which we do not like.
What?
Which we're not a fan of.
Which we're not a fan of either, and it's wasteful. So I do appreciate that, you know, there's little things like, could we just get it together so you only needed 1 contract if you did business with any of the health departments, to the fact that the contracting process in and of itself is a barrier for some of our best providers to be able to get into our system and get what are taxpayer dollars, whether they're federal dollars or state dollars or county dollars, they're taxpayer dollars. And we need to figure out a way to make sure that while we're accountable to making sure that the money goes where it ought to go and that it's used appropriately, that accountability shouldn't come at the expense of both innovation and creativity, as well as I think on the backs of the smaller community-based organizations that don't have capacity to be successful on our solicitations. So for me, those are 2 very big issues. One is, how do you get the contracting process amongst the 3 departments to be streamlined and efficient? And the second is, we've got to create a whole new way of doing business that allows us to really honor creativity and innovation and bring in many more of our community-based partners. I don't think either of those are going to be easy, and I don't think they're going to happen quickly, but I share with you the goal of it cannot take us 2 years to do a solicitation and make awards, nor can it take us 2 years to do solicitation and awards that leave so many organizations out of the competition. So, you know, and I'm not the only department. I feel like I can talk freely about this because this Parks Department has this issue. So it's not just the health departments. There are other departments. Department of Public Works has this issue. Anybody who's trying to do more community engagement, trying to bring in community-based partners, is really struggling with sort of what I would say is just somewhat of an antiquated bureaucratic system that's not as responsive as it needs to be. And I will say, here's where technology ought to be a benefit. We ought to be able to use some of that technology to make the whole process easier for people to both get information about the solicitations and actually compete. So you've got, I mean, the only thing I think I can say is you have my pledge that this is a high priority issue for our department, for the 3 health departments, and we have, as part of our equity work, we've elevated it to a county platform. It's one of 3, I think, initiatives at the county level to address an equity issue as part of the equity agenda for the county.
And I'd just like to comment on the safety net. You made a really important comment about the safety net and the holes in the net. Here in Los Angeles County, thanks to the Affordable Care Act, we doubled the number of community health centers in Los Angeles County. The health centers and community clinics in LA went from seeing 60% uninsured to 60% Medi-Cal. But to your point, when we talk about the safety net and folks living in poverty, our safety net is largely focused on the folks who live below 100 or 200% of the federal poverty level because of the high need and the lack of access and resources for that population. And we've been trying to move up access. It is really hard. When you go to places like Humboldt County, for example, the mayor of Humboldt goes to the community health center. Everybody in the community goes there. That is the access point. That is the safety net for everyone. We don't have that here because we have so much unmet need. I should say we don't have that yet. We don't have that yet. But I recognize you made an important point about that, is that there are, and there continue to remain, big holes in our safety net and people that remain unserved.
Yeah, I did want to just add on a couple of comments to what Barbara said. I do want to recognize, Barbara's been with us for 2.5 years, and when she sees some of the processes in the county, it's very eye-opening. To say that it's challenging is probably a nice way to describe it. And I know that Barbara really is committed to finding whatever way works best to get things done quickly and appropriately. I do know that Maria's group is also very creative. When we got funding, I know Mario's like the fastest way to get this is A, B, or C, right? I know you think that way all the time, Mario. So there's this constant thinking about trying to get around the 18-month or 24-month. For example, the recent funding that the board provided for HIV and STD testing, I think that money was given out in November, so we're just about to get that money out a little over 12 months, but if we could shorten it, we certainly would prefer it. And I also do know, and I can't really get into details, that there are debriefs when we look at what happened to figure out, is this what we really wanted to have happen? And are there some things we could improve here to address the kind of things that Dr. Ferrer mentioned? So I can just tell you that the issue you described, we own it like you do, trying to figure out how to improve it. And I know we always communicate with the board what the impact of these delays are. But even beyond that, we're trying to do all we can to address it.
Could you hear me? Okay, thank you for the presentation. My name is Abad Lopez, an affiliate consumer from SPA2 and also HIV commissioner. I have 2 questions for you. The first one is, even the increase in homelessness based on the last homeless count results and knowing the public health impact for people living with HIV on the streets may have, how will DPH prioritize housing for this population? This is my first question. And the second one is, what can the community do to support DPH and the Community Clinics Association of Los Angeles County efforts in ending the HIV epidemic? Sorry for my British accent.
Very clear.
I'm from Mexico.
Very British.
You want to respond to the first one?
Yeah, no, muchas gracias, and it was clear, and both were important questions. The issue of homelessness is probably, in many ways, the most complex issue that the county faces. Although I think some of the solutions are relatively simple, were there to be political will and community support. I do want to say that one of the biggest obstacles to housing for people who are homeless are the responses you get in places like Chadworth and Long Beach and Santa Monica. You go down the list, you know, for the very same communities that voted for Measure H and HHH, tax ourselves, when it comes to citing housing, are adamant that the housing, for whatever reason, doesn't belong in that neighborhood. There's a school, there's a store, there's a playground. When you live in dense environments, school, stores, playgrounds, daycare centers, they're everywhere. And if you want to find a good reason for not moving forward with housing for unhoused people, unsheltered people, it's going to be pretty easy. So I think until there's political will amongst our community residents to step back and change zoning requirements and building codes so that we can actually increase production of affordable housing units in places where people need to live, we face a losing battle on being able to house people who are currently homeless. And then we have a whole bunch of policy issues we have to deal with to keep people who are vulnerable to becoming homeless from coming into that horrible pipeline of falling out of shelter. In terms of, you know, sort of who decides the prioritization, I want to say that DHS runs the Housing for Health program, which really tries to take into account the variety and complexity of people's lives, including medical diagnoses, around making sure that people are, in fact, sheltered as rapidly as possible. And, you know, from their perspective, they've been moving most aggressively on permanent housing and permanent supportive housing. I would say, from my perspective, it would be nice for us to be as aggressive on interim housing. I don't think anybody should be living on the streets. I don't, I'm not, no one agrees, I mean, not everyone agrees with this, so, and I don't get to decide, but from where I'm sitting as a public health director, I don't think anybody should be left to live on the streets. I don't think that's freedom. I don't think that's justice. I don't think that's entitlement. I think entitlement is that you have a safe place to live, and it's a shelter, it's sheltered, and it's with services and support, and it's respectful. And I think we need to move in that direction. As long as we leave people and we tolerate places like Skid Row, we're going to have a very hard time supporting people who are ill, whatever their illness is. And the mortality rates that we're seeing are astronomical. And I want to put these mortality rates in juxtaposition to why it's so troubling. New York City actually has more homeless people than LA County. They have about 63,000 homeless people. Unlike LA County, the vast majority, over almost 80%, 85%, I think, of their homeless residents are sheltered. Last year, or I think 2018, they had 218 deaths amongst all of their homeless people. Last year, LA County had over 1,000 deaths, and we have 59,000 people. So we have less people and way more deaths. Now, I would say when we sort of look at this more deeply, we are going to find that the difference between New York and LA County in terms of mortality is sheltered versus unsheltered. And that, in fact, sheltered people, because the national data already is showing this, sheltered people do better than unsheltered people. The solution to the mortality issue is a home and resources, economic resources. In the interim, we need to get people off of the street. And we need to be just as aggressive about housing first, just as aggressive about interim housing as we are about housing first. And I don't see us getting to a solution for people who have a diagnosis of HIV or living with AIDS and are homeless unless we actually tackle this bigger issue of people need to have an entitlement. You know, in LA, in New York City, you are entitled to shelter. In Boston, you are entitled to shelter. In Philadelphia, you are entitled to shelter. And there are different options. And it's not all perfect, but no one should be dying on the street because we left them in an unsheltered situation.
Regarding partnership, thank you for the question. I really appreciate Dr. Ferrer's comment about contracting. As one example, I'll use DMH since I don't think they're in the room. But we had an opportunity for our members to contract with the Department of Mental Health for our indigent care program, which is now known as My Health LA. And this is a while ago. And so all the clinics stepped up and they all got contracts with DMH, and it didn't work. It was a failure. They had different systems, different billing, different audits, different mechanisms, and so it was awful. Now, and I'm saying a nice thing about them, so everyone just pay attention and put a pin in it. They came back and said, okay, we need to do something different. So they actually contracted with the Department of Health Services, and they're giving money over to the Department of Health Services to add a mental health benefit to My Health LA under the existing contracts the health centers already have with the Department of Health Services. One audit, one contract, one payment system, so much smoother, and that's what integration looks like. So to your comment, I really appreciate, and to the place where we can try to reduce the spaghetti on the contracting map and get to unique channels and try to align priorities and goals, that's just one example of partnership. I think there's many, many others, but that is one, and I really appreciated Dr. Ferrer bringing it up, because also on top of each contract, there's administrative burden. And so we're spending more time on the audit than we are on the care. And so I think that's just another example of how we can make it simpler.
Thank you.
Hi, thank you. I think the four of you know me. Aaron Fox, I'm in the Part C seat on the commission, and I co-chair the Public Policy Committee with Katya. I want to sort of bring us back to HIV and HIV prevention and the plan. And when the director of the CDC was here, Dr. Redfield, he, I thought, went way farther than I've heard other administrators and directors go, especially when talking about PrEP and the implementation of PrEP and PEP. And he said that we need to be radically innovative. And what was it? Disruptive. Oh, that's right. Disruptive as well. I like those words. Like, I love hearing those words from bureaucrats because you never get to hear them from them, right? So we've heard that from the CDC. I think the state has been very clear about their commitment on PrEP. We've seen it in the state legislature. We've seen it from the governor, all the way down. There is a real concern within the community here in LA that Dr. Ferrer, that your responses to certain questions about sexual health and PrEP specifically have been at best lukewarm, and that your position on PrEP is not at a place that would be in congruence with ending the epidemic. And so I have two questions. One, are you willing to say here today that you would commit to being a champion to increasing PrEP and PEP uptake in LA County? And two, are you also planning to integrate PEP and PrEP services in the school-based healthcare plan that you talked about earlier?
I'm a little surprised at your question because I've never indicated anything but support for PrEP and PEP, with the exception of the issue where I was asked, would we be able, when we opened up at the school-based health centers, to be able to do PrEP and PEP, and I said only the PPLA, only where we have the PPLA full service reproductive health services were we going to be able to do that at this time. It would obviously be a goal of ours to expand sexual health services, and that's the partnership with PPLA, that we would have those services in all 50 of the sites. At this moment, PPLA is only going to be in 5 sites, which is the limiting factor. So I've never indicated to you or anyone else that the leadership at the Public Health Department isn't fully supportive of PEP and PrEP, with the exception of this issue related to the student well-being centers. I'm not sure, you know, I've been really clear that we stand behind the plan, the strategic plan. We stand behind the implementation of that plan. We have released an STI sort of a request for proposals that actually included in it language that said you couldn't get money to do STI work unless you could also do PrEP and PEP. So, you know, I'm happy to sit with you and get some better examples of where you feel like we might be falling short. But I know the Student Wellbeing Centers is the one place where I've said we can't do that service without having the appropriate staffing, and we won't have the appropriate staffing in 45 of the sites when we open.
Well, then it would be very easy to clear it up if you just agree to use your directorship for being a champion.
Of course.
Oh.
Of course.
Okay.
I'm happy to.
Great.
So.
Excellent.
Thank you.
Hello, I have a two-part question. The first being, my belief is that we need to place as much emphasis on saving the mind as well as the heart. Because if you save the heart and the mind is not well, that mind is not going to be able to continue the good work that we might have done to save the heart. I do have tremendous concern that we do not provide enough mental health care for those people who are affected by this disease and any other disease. I am also concerned, the second part of my question is that we focus on those who are at the bottom of the economic arc. But what about those who are just above the poverty level? They cannot receive access to the community clinics. And many people in that income level also do not have health care. And until we get our national health care or health care for all situation solved, we need to focus on those people in the middle and those people who need access to quality mental health care affected by this disease or any other chronic illness. Thank you.
Amen. Amen. I'll touch on the mental health side of this first. One of the many good things that came out in 2014 was mental health parity, in saying that if you're going to offer medical services through a health plan, you have to offer on par level of services for mental health. And so we were actually able to bump up, and I'm going to touch on the low poverty for a second, and I'll get to the second part of your question. We were able to bump up services for our Medi-Cal delivery system because suddenly the people in the middle, which are often the people who are just low acuity, they need some short duration services, they're not seriously mentally ill. These are people for whom we can prevent them from getting there. We actually added the benefit. Now, but we gave them a hunting license, right? Now your card says you're covered, but doesn't mean there's a service there that we can provide you. We've struggled with the workforce, which has been a real challenge, and we've struggled mightily with, and by I say workforce, I mean hiring. So marriage and family therapists, for example, are a wonderful resource here. They're often more likely to be culturally competent, to come from the communities they serve. But if you work at a community health center, those services are not billable because the State Department of Healthcare Services would rather we just provide those services and not get paid. So we did get a bill through, and there's actually a state plan amendment going through that is going to add marriage and family therapists to the list of billable providers for community health centers. So that's part one. Unfortunately, another bill we just had this past year, the governor did not sign, and he didn't veto it, though. He didn't veto, was for us to be able to be paid. And I hate that it's about payment, but unfortunately, when you're a nonprofit, you are thinking about your bottom line. If we provide someone a medical service and determine that they need a mental health service too, we have to eat the cost of that mental health service if we provide it on the same day. And so we brought a bill to the legislature. I think it's our 5th or 6th time. We've been vetoed. We just keep coming back. And the governor said, well, I'm really happy to get 2 for 1. Why would I sign a bill that's going to cost more on my general fund? So we're going back with them. We're not done yet. We're going to keep pursuing that because we know that same-day visit is one of the ways that really helps people. If I tell you to come back tomorrow, you're not coming back. How many bus rides is that? Parking costs, you name it, childcare. That's a problem. So we're going to keep working on that. On Medi-Cal as well, there is a state proposal called Cal-AIM, and I want everyone to pay attention to this. This is a really huge global undertaking that would revise how we do healthcare services in our Medi-Cal delivery system, including mental health. More to be determined on that, but in the coming months, we're going to be weighing in to really think deeply about how can we improve the delivery of services and the integration of services under this state proposal, which is going to have to go into a waiver with the federal government. Now, on to the piece about folks who are above the federal poverty level. And honestly, you might be making $1 more or $1 less, and you're coming in and out of covered California or Medi-Cal or uninsured and Medi-Cal. We don't have the solution yet. We're working on it. Luckily, we do have folks like LA Care Health Plan that actually participates in covered California. That's uncommon for a public plan. They're the only one in the state, the public plan in the state that participates in covered California. So if they see one of their Medi-Cal members make a little more, and rather than kick them out, they say, hey, we have something else that you can stay enrolled in. So it's not the end-all, be-all, but it's a start. And I think that what we really have to do is continue to add access points so that the community health centers can see people as they move up the income ladder and continue to serve them and not just be wholly reserved for folks who live below federal poverty or who are low income. So that's my piece on that.
I think I also think it's a great question, and I think emotional well-being is. I so appreciate that you raise that issue because I think emotional well-being is sort of core to us being able to be functional, and I think you're absolutely right. We often do a disservice by not paying enough attention and not having enough services. But I also challenge us to sort of broaden our definition of what we could do to support emotional well-being, because it's not always necessary for it to be a treatment service. Emotional well-being, starts with building in opportunities in schools for our young people to learn the skills around managing their emotions and managing their relationships with others.
Especially in light of today's shooting at
Exactly, and especially just the turbulence and the complexity of everyone's lives really demands that we be way more proactive on supporting young people as early as they enter into daycare and school. So I think there's a whole bunch we can learn from programs like Head Start and how they involve families and support families, because some of emotional well-being is also about support, and I don't want to lose sight of peer-to-peer relationships and, people.
But with a disease like HIV, where there is a stigma, peer-to-peer may not be the best option.
Right. It may not for some, and for others it may be. So, I just think we need to really look at what works, in different settings and also for different communities, and so that we can be both culturally appropriate and linguistically appropriate, and really focus also on supporting emotional well-being without necessarily waiting for somebody to be in a crisis or for them to need a diagnosis in order to access services. Because I do think mental health and mental illness is one part of a continuum of support that we could give to folks. So,
thank you.
Thank you.
Hi, I'm Jason Brown. I'm a commissioner, and I also served on the Integration Advisory Board for 2.5 years, and I was a co-chair of the Diversion of Corrections Committee. And as you know, Barbara, I'm the big proponent of getting people services and everything they need coming out of the jails. And I spoke to Mario earlier about it too, but are you going to sit down with Judge Espinoza, the Office of Diversion and Reentry, and come up with something better than, you know, what you have now, and possibly even bring in the sheriff too, and, you know, increase the number, not only the number of tests, but trying to figure out the drug system to get PrEP and PEP in the jail.
You know, I love that question. I do want to say that we meet regularly. The CEO has actually convened a working group, and the sheriff is represented on that working group as well. And Judge Espinoza and I have been like talking, you know, sort of every week around a host of issues. I know that Mario has been sort of the biggest champion for making sure that our jails do a significantly better job on providing services and support. And you know, I've met a couple of times with I don't want to call them correctional health folks to really try to figure out why we can't make the progress that we ought to be making with folks who are both in custody, but also folks who are leaving the jails and going back in a reentry program or reentering our communities, and what are the links. I do know that Mario has staff there now that are really sort of supplementing the correctional health folks. I think it's an ongoing issue, but I know we're working hard to try to make much greater inroads in sort of what would be appropriate services. You know, I'd like to say, you know, the area where I think we need to work a lot harder is on the reentry side, and that's in general. You know, I think as folks are being discharged or they're entering into a diversion program, I'm not sure that we're able to do all that we ought to make sure that care is constant. And again, you know, partnerships with the clinics is going to be essential as folks leave. You know, Massachusetts, the clinics actually sent people into the jails before people got discharged, so that they actually could sign people up and they could start providing care while people were incarcerated, so that then they actually had a medical home when they left. So like Hampden County had a great model in Massachusetts where they really sort of piloted, you know, other approaches to make sure that people both got what they needed while they were in custody, but also didn't lose traction when they left. So.
And just, I mentioned CalAIM before, but if you are interested in the incarcerated, you know, in folks in jails as well, think about the CalAIM proposal. Within that is a mandate that anyone leaving custody is getting enrolled, so that they're really focusing on coverage for folks in the reentry population. So just enrollment as part of the CalAIM is going to be a key piece there as well.
One last thing is, you know, we do need legislation that allows, at the federal level, that allows us to actually have people not lose their coverage when they're incarcerated. This is especially important for the people who are going into the jail, because those people are often, 50% of the people in the jail are actually not convicted. So the fact that you're in jail and you lose your coverage makes no sense, and it really wrecks the sort of relationship building. It also makes it very expensive to provide services in the jails, because the county has to absorb 100% of the costs, when really for those folks who are eligible for Medi-Cal, we ought to be able to draw down on the federal match. So I think, you know, this is particularly onerous, I think, when people haven't even been convicted of anything and they've lost their coverage. I mean, that makes no sense to me. And I think, again, there's a lot of advocacy that needs to be done so that we don't waste our county taxpayer dollars on something where we ought to be getting somewhere between 50 and 90 cents on the dollar in our federal match.
Okay, we've only got about 5 minutes left, so we have folks over here, and let's see if we can get both of them.
Hi, I'm Lee Cochums. I'm commissioner. I sit in the social behavioral science seat, and I'm also caucus. I'm an unaffiliated consumer. And related to Jason's question, we serve very vulnerable populations. As I listen to plans of integration, and what sounds like us a bigger bureaucracy, most vulnerable populations often get further away. Now, thank you for coming, and standing up before us and answering some of these questions, you talk about integration where it's worked and where it hasn't, and that makes me encouraged. Some of our most vulnerable populations are transgender people, men who have sex with men of color, women, youth. What are some specific strategies going forward that you're going to be using to make sure the needs of those vulnerable populations are met? And then is there an overarching goal or an overarching plan where that taking care of vulnerable populations kind of brings all these different stakeholders together in some way? Is there a vision?
So I don't know if I have an easy answer or even an answer at all. I have some ideas. You know, I'm hoping we're not creating a bigger bureaucracy. I don't think that's the intent at all. I will, you know, I'd love to make sure that you get a copy of sort of the draft proposal that lists out the strategies and some of the metrics, because I think you'd see sort of a deliberate focus on the most vulnerable, and that the work around integration, at least for the next 3 years, is going to be primarily focused on the most vulnerable. And, you know, that's been defined explicitly by the board to include some populations, and then by our equity plan to include others, including people who are transgender and men who are having sex with men, people of color, young people in general. So I share the need for the focus to be on those who are most vulnerable. And in fact, for me, it's for those for whom inequities are part of everyday life. So, you know, I don't think it's give services to everybody and you know, all boats are going to rise. I've seen no evidence that that works in my lifetime. I've seen not one single example where, you know, you just, you know, send out all the resources to everybody, and because you do that, the inequities actually get smaller. You know, for infant mortality, the evidence is pretty clear that we may have improved the infant mortality rates, but the gap between white and black babies dying every year just got bigger in some cases, and it certainly stayed the same. Until you do targeted interventions that really understand the complexity of both the conditions and the lives that people are leading, you're not going to really, I think, address the root causes of what creates the inequities in the first place. And that's a power distribution issue, and that's a distribution of opportunities and resources. So I think the commitment, if we're going to truly address the issues for those who are most vulnerable, is to address the issue around the distribution of resources and opportunities that people need to be healthy. That includes addressing straight-on issues related to racism, stigma, and discrimination and bias. And we're not going to get away from having those tough conversations and aligning policies and strategies and practices to address both historical legacies and current policies and practices that perpetuate those inequities. So that's why I don't think there's a simple answer, because I think the work is very complex. But I don't think we actually will make any progress if we don't deal with the complexity. There's no single bullet solution to this. I think you have to start by calling out the truth when you see it, and you also have to start by dispelling the false narratives that are being perpetuated, whether intentionally or unintentionally, by many well-meaning folks, including the Department of Public Health. You know, we have to be way more conscious of what it means when you put up a chart that shows that black people, Native Americans, Pacific Islanders, Native Alaskans all do far worse than everyone else. Because if that's all you show, then everybody walks away with what I would say, or lots of people walk away with the false narrative that the people with the worst outcomes are somehow contributing to the conditions that allow them to have those worse outcomes. So you have to be really intentional about showing that, in fact, that's not the case, that we have ample evidence that shows that that's not what causes the inequities in the distribution of disease or mortality rates. and be very conscious of showing what does contribute to those inequities, and then aligning our resources to redistribute the opportunities and resources people need to be healthy. And I think, stigma is a huge issue. And it affects the way people get care and the kind of care they get when they get into care, as does discrimination and bias. So, we have to acknowledge that, and then we're going to have to put resources towards fixing that problem. We're going to have to acknowledge that we have policies that tolerate people not getting jobs and not getting housing because of who they are, who they who their partner is, and what they look like. So you'd have to tackle all of that, I think, to get to what you're saying. But I don't think we're creating a bureaucracy to tackle that. I think we're trying to be very intentional that the most important piece of the work is the partnerships we have with people who have lived experiences. And the leadership that comes from people in communities is the leadership that's going to help us find the right solutions. So this isn't going to happen because I do something or Christina Galley does something or Dr. Sharon does something. This is going to happen because we have way more effective partnerships with people who have lived experiences and community organizations that have for years led the struggles for justice. And we have to become part of those struggles and be supporting of those struggles.
We've got to cut off here or we will not get the rest done that we need to get done. So if you didn't get to ask your question, please put it on a note card and give it to Cheryl or one of her staff. And we're going to take a break till a 10-minute break, and then we're going to go into small groups and ask you to do some very specific things about recommendations for what happens next around community engagement. Thank you all so much. It was extremely helpful.